Welcome back, everyone. Can we just give it up for a moment to the incredible expertise reflected in this room today? All of you. I'm Hans Johnson, president of Progressive Victory, based usually in Los Angeles, but pleased to work with the Peggy Lillis Foundation for the past 6 years. Our panel this afternoon is on DIFF and patients' rights. In addition to PLF Executive Director Christian John Lillis, we are exceptionally pleased to be joined here today by Eileen Carina, here from Long Island, and a longtime advocate with Pulse of New York on preventing infections and on raising awareness around infections. And the program director for Consumers Union and its sister organization, Consumer Reports, the wonderful and highly esteemed Chuck Bell. So we will have time for questions built into this rapid fire panel, but first, I wanted to just frame a little bit about what we're talking about today. We're talking about the intersection between personal advocacy, between legal recourse around infections and injury from infections, and we're talking about patient rights. And the three gears I would just invite us to think about in the background turning are the various ways in which we as citizens can seek recourse through the democratic process and through the law. Some of us operate from a clinical context in which we approach things from a cure-based perspective. Oftentimes, when we are, especially at the lower levels of governance, at the local and municipal levels, we find that policy is driven by complaint-based systems. How many of you have experience with complaint-based government at the local level in particular? Right. Sometimes you'll actually have transparent municipalities or governments that will actually say, we are a complaint-based system, so the squeaky wheel gets oil. And finally, let's think about that third gear that is an undercurrent for much of our discussion today, which is around systemic reform and policy change, which many of you in this room know deeply is coalition-based responsiveness. So keep those three gears turning as we have this conversation this afternoon. We invite your questions. And I want to make sure that as we get rolling, we go into first discussing around patients' rights. The first segment is from Christian about progress being made on accountability for patients, and he is going to discuss how we have made it into a place where we can actually talk concretely about a patient's Bill of Rights. Christian.
Well, you and I are going to do that together. Me and Chuck are going to do that. So we do have a handout. This is actually from Johns Hopkins, because I'm kissing up to Sarah Cosgrove. But there are, at most states have a patient's Bill of Rights. This one happens to be from Maryland. New York has one. Some of them are legislative in nature. Some of them are many, many pages long. Some have patient rights and responsibilities. But often when we go into the hospital, we are asked to sign that we've received this. But people don't read it. They don't understand how much of it is based in the law and their ability to actually have these rights met. I don't think they understand whether or not those rights are violated or not, and what recourse exists for them to be able to take action, when these rights are being violated. And as some of you may know, I spent a good deal of my career in the LGBTQ rights movement. That's how Hans and I originally met each other. And so, the fight over many years to have those rights acknowledged, I bring that to this work in terms of thinking through, first, I'm a citizen, and so I have rights as a citizen to not be harmed, to not, I have consumer rights, whatever you want to call them. So that's something that we wanted to point out was the Patient Bill of Rights. And Chuck, I think you were going to talk a little bit more about that in the New York context.
Yeah, sure. So we actually had an effort in about 1999 to 2001 to try to create a national patient bill of rights, which was debated extensively by the Congress. And this was sort of coming out of the period where Americans were herded into HMOs and managed care plans. There was a lot of frustration about your rights to seek review if you needed a particular treatment or surgery and it was being denied by the insurance company. That really came to the fore. And so out of that period, there was this debate in the Congress, and they were unable to agree. So I think the House passed one bill, the Senate passed another bill. The negotiations to bridge the two approaches failed. And so in the aftermath of that, quite a number of states passed a patient bill of rights that's actually in statute. So for about 25 states, it's actually in the law. And so there are some binding aspects of the patient bill of rights. And in New York, for example, we have a 44-page explanation of our patient bill of rights. Which I printed out. Now, one thing we have noticed at Consumers Union is people, by and large, don't know that they're entitled to anything in particular. So if you have a problem in the healthcare system, they're much more likely to talk to the provider or call the health plan. It's only, sort of in the outside world where we learn about structures of accountability that we start to think like, oh, a government must have oversight of some aspect of this. And we have rights, generally speaking, as consumers because previous generations of consumers and people demanded those rights. And the system eventually responds, but it's very slow. So in New York, for example, you have a right to file a complaint with the State Department of Health, and your complaint will be, it says it will be investigated by the Office of Professional and Medical Conduct. And so so in our case, that might be more binding, but Lisa McGiffert from our Safe Patient Project, who's stationed in our Texas office, she says there's lots of bills of rights out there, but a lot of them aren't worth the paper that they're printed on. And, people need to insist on the rights that they should have, right? And so I think in some ways with C. diff, you are in the situation where your rights are not adequately protected. Just as in the case when I moved to New York, there were not protections against discrimination on pre-existing condition. And we were reflecting last night that actually ACT UP and the AIDS activists actually pushed for a lot of protections that we have today because of the discrimination that they faced as individuals. And so when we think about something like the social right we would like to have to be able to go to the hospital and not get infected, this is something we have to construct as like a social movement because it doesn't really exist in the form we would like to see it today. And then if we've been wronged individually as patients and we're seeking justice, like civil justice, which we might need to require us to file a lawsuit, a lot of those suits don't succeed. You have to have a particular pattern of facts. The providers and the hospitals are very good at defending their position. They have extensive resources and access to medical experts that they will bring in that will testify against you. So it's very difficult for the individual patient always to get justice in the particular case that you have, and so it can be extremely frustrating. But on the complaint side of things, in terms of filing a complaint with the State Department of Health, we think that's a very important thing to do because the system for society as a whole, because the system does respond to patterns of complaints, and the more detailed your complaint is when you put it in, the better chance you're going to have that someone is actually going to launch a more serious investigation and start to hold people accountable.
Yeah. The one thing that I would add to that, and we are going to talk about sort of litigation stuff in a little bit, but I also want to hear Eileen's thoughts, is that Amanda was doing her session earlier about advocacy, and Hans and I talked a little bit about this, but the reason why it's important to file these complaints, and there's a similar thing, like if you think clindamycin was the precipitating factor for C. diff, then you should go on the FDA's website and you should report that that was a side effect of clindamycin. These, I think, Chuck, ACT UP is a good example, and even the baby boomer generation is a good example of these rights struggles that we all inherited. And I don't think that Gen X, maybe the late baby boomers, I don't think we've been good stewards of those rights, and we've allowed them to kind of get stripped away from us. And so I think that it's very important that these are things that you have to use the muscle to keep it going, right? So, if no one calls the state health department, then yeah, they're not going to do anything. But if everyone in this room showed up tomorrow at the state health department and said, you know what, we're really sick of this C. diff nonsense, they might have to do something about it. So I know Eileen has done a lot on individual patient rights and helping them focus on theirs.
Thank you. I just wanted to comment on that because I see the Patient's Bill of Rights as if you're giving somebody the driver's manual and the keys to the car for the very first time. So, go in the hospital, you're having a heart attack, you're sick, you have a car accident, whatever it might be, and then you're given this Patient's Bill of Rights to read and sign that you received it. And that's our focus as an organization, that we teach this information to the people who aren't in this room, the people who are out there and may never have an opportunity to hear this information until it's too late or until they're in a position to go into a hospital. Whether it's high schools, middle school, we do this education in health classes and want the young people are young enough to know that they have rights in a hospital before they go in. So that's my touch on, or my thoughts on the Patient's Bill of Rights. It's interesting. It's our rights, but you're giving it to patients who aren't going to read it because they need to take care of themselves. The family members, as advocates, and we train advocates, the family member may want to read that. That's something that they could do at the bedside or when they come in. But asking a patient to sign off that they read and understand a Patient's Bill of Rights, for 20 years I'm doing this, and that's, I think, the problem, is that we're expecting patients to have this information when it's so inappropriate.
And it speaks to the need for broader range understanding and consciousness around citizenship and civics. That when you're talking about a point where something like a Patient's Bill of Rights is relevant, if it's falling onto untutored ground, if those seedlings are being planted in fallow turf that hasn't been irrigated by years of training or education around what it means to be a citizen, to seek recourse, that there are channels of involvement where your voice can be heard and where your responsibilities are, where others are responsible for working on those complaints or on those grievances, it has much less utility. And I hope that we can see this as part of an ongoing cycle of advocacy and of awareness that tools like Patient's Bills of Rights can be especially efficacious for.
If I could just add, I think these agencies that accept the complaints, like the State Board of Health, have not done a terrific job of holding themselves out there and actually marketing the fact that they accept complaints. So it's not as if they've established kiosks on on the streets and say, we would like to accept your healthcare complaint. And so we did a poll. I work a lot on medical billing issues, and we did a poll. We said, as a consumer know which agency in your state oversees health insurance? And it's usually the Department of Insurance. In New York, it's the Department of Financial Services. 83% of people didn't know which agency they would even go to for something like that. So I think one of our jobs as advocates is getting these names to be in the front of popular consciousness, so people who get a C. diff infection can make the beeline to that agency and beat down their door.
You want me to talk about the complaint process?
You're from Long Island.
Do you have to tell people? Well, I think that's one of the reasons our organization started. We started as a support group for survivors of medical injury because it's so hard to file a complaint. And when you do file a complaint with the state agencies, who's overseeing them? And who's going to follow up with that? And who's going to answer? Who are they going to answer to? So instead of the only option of filing a complaint with the state is to talk about these experiences, get these stories out there, allow patients who have had these experiences to share information, and to bring it home to the C. diff problem. As an educator in a group of 20, 25 people, early on, many years ago, I did a presentation about the importance of hand washing, healthcare professionals washing their hands, and we often work on that really difficult conversation of asking a healthcare professional to wash their hands. But, when somebody asked, well, is the antibacterial lotion good enough? My response was yes. And at that point, somebody shot up, and this is going back about 8 or 10 years, and said, no, my mother had C. diff, and told a story to this group of 20, 25 people. And I didn't know if she was telling the truth or what, I didn't know who she was, but I followed up with this group. 25 people were now educated in the community, in a small Long Island community, And hopefully they'll spread the word about what C. diff is. And no, it's not just okay using antibacterial soap in many cases or lotion in many cases. So the community educating each other before this happens could avoid the experience to begin with. But then when filing a complaint, having the community support around when the complaint is filed to follow up who's going to be watching the chicken coop, so to say, and how do you get this information out there, and what are they doing with it when they do file a complaint? Is it a slap on the wrist? Is there a fine being paid? And then what? And then all the doors get closed and everybody goes on and continues catching diseases.
Could you talk briefly, whoever wants to field the question on this issue, around the value of plural approaches? I think sometimes we think about having to take the right approach, or what is the one responsible agency. But could you talk about the value of having multiple approaches, legislative accountability over agencies, local as well as state level, or even federal oversight or channels of complaint? Chuck, why don't you take that on?
Yeah, so the system of oversight that we have is incredibly fragmented. So as a layperson, you wouldn't even be prepared for the number of agencies that you could actually go to bring your case. And so, for example, in the state, you have the Department of Health. You may also have a department that licenses hospitals and accepts facility-specific complaints for hospitals. You may have a peer review organization. In New York, it's been called IPRO. And so you can go to that organization that's charged with sort of maintaining quality standards for hospitals and give them a copy of the complaints. In the Medicare space, because everyone who is enrolled in the Medicare program has the right to complain about actions by providers and by hospitals. And since that has a national basis, that has a nice, it's a nice large program of accepting complaints. And hospitals really do have to respond to what Medicare says, because every hospital wants to accept Medicare as a payment source. And so that's a very important channel. We also have the Joint Commission that accredits hospitals is another place that you could bring a complaint to. And how would any consumer knows this? So it's not a front of mind thing, but I think every one of these agencies is a potential pressure point. So if you do a very good job of writing up your complaint in detail, you really should, submit it to 7 or 8 different places as a way to pressure the system and try to get them into action.
And I would just generally say, so I think that as human beings, we are terrible at policing ourselves and our community. I think you can see this with everything from police departments to Congress. Congress manages to give itself a raise every year without passing a budget. So who has to oversee, So it's we the people that are supposed to be overseeing Congress, right? And I think you can see this at the smaller scale at the state level. And so if no one's paying attention to what the state health department's doing, then they're just going to do kind of what they want to do. And it doesn't actually, I think a lot of bad things can happen because people aren't paying attention. And I think our entire sort of democratic system here is based on this idea of tension, where there are competing groups, right? And so what Hans was getting to is so if there are people who are paying attention to the insurance part of it, and there are people paying attention to the quality part of it, and we're all kind of communicating, but also kind of keeping each other honest, then we have a good result. It's when one group gets too powerful, or when the other group gets to not understand that their rights have been eroded, that we start to see a problem. And so I think that's why we really have to be, to take all of those channels that Chuck pointed to and to really be kind of persistent about it.
Yeah, can I say another thing? So I think it's also important to make noise to the media or to the community when you're putting in your complaint, because they're used to receiving them one by one, and having more sunlight on the situation and sharing the story more broadly, I think can be very effective, whether it's on your website or with sympathetic reporters. And then another aspect of this is that providers and hospitals have strong trade associations that represent their interests in the state capitol and with these agencies. As consumers and patients, we're dispersed in the marketplace, and we're all kind of there on our own. We're busy with our lives. And so it's very unusual, I would say, for like state departments of health to get a visit from 3 or 4 members of the community that have had a C. diff infection in their family. And I think that they would be receptive and open to having more contact with advocacy organizations of that type, but there's, because of the time it takes and the expense to like take a train up to Albany or whatever, it just doesn't happen very often. But I think it's very important that they see our faces and hear our voices, and we create some sort of regular structures, because that would be a way for them to realize that they have to be responsive to this constituency. There's a constituency for medical harm. There's so many patients that have been harmed, and we want to be part of the conversation. And another channel for that obviously would be if there were patient representatives on the board of the hospital itself. So that's another channel to pursue. Like, it's kind of a long way around, but really hospitals or other institutions, nursing homes, should have a point of contact for the family members and the patients to be regularly represented so that infections are reduced and there's accountability for these practices.
I only have one comment. Chuck, who's going to pay for the neighborhood to go to Albany or Washington?
Yeah.
I mean, you know, the hospital, well, that's, yeah, and we've been trying for 20 years, you know that. And the idea that hospitals and nursing homes have lobbyists, they have health, there's unions, there's all kinds of people that's what their job is. And if I'm going to get 5 people up to Albany, I'm going to be paying a couple $100 a person, and that's not going to happen. So I'm just to touch on one other thing. When somebody does do that letter, and for years we've been helping people write those letters, is we ask them to have a solution, not just this is what terrible thing has happened. What is your experience, and what could have been done different, or what would you like to see change? So they're coming out with a goal of a solution also, not just, and I hate the word complaint, but not just a complaint of what happened, but here's my experience. Very often, there is no conversation with the patients and families when they do what's called a root cause analysis, and they study the incident, and they study the experience and look back at what happened. They're leaving out the most important person in the conversation, the patient and their family members who are at the bedside, who are with the patient 24/7, and may have seen what would have led up to a terrible experience, and might have been stopped if the patient or family member even knew what they were looking for.
Yeah, I want to touch on two. I want to touch on one of the things that that Eileen just touched on. A big part of the money that we raised for this event, and that we're very grateful for our sponsors for, was to actually bring people that have been harmed by C. diff from all across the country to be in this space, to network, to educate, to be activated, and that is an expense, and it's not something that people, especially somebody who has been ill or been harmed, they may not have that extra money, that extra resource. So it is something that we probably need to raise money for. I guess because I'm a professional fundraiser, but I would not be so poo-poo about the idea of it, because we, through Consumer Reports, I recently met two groups of women, primarily women, women who have been harmed by e-shore, implantable contraceptives, and also women who have had breast implants go bad. And these groups of women have Facebook groups of 50,000 people, and they pass the hat, literally. They raise in $5 and $10 increments money to send 5 of them to DC to lobby. And so there is a way when you build the big community. I mean, and that's, I think, the lobbying part of it. Sure, of course, the professional associations and the people, they're going to follow their interest, and we just have to create a countervailing force to that. And not like, I don't want it to sound like that adversarial, but like everybody's voice has to be heard at the table. And I think we were talking about this. Been talking a lot with the fabulous women here from Shea. But how do we figure out like what the thing is that would actually help all of us? So I do want to talk about the litigation thing in a minute, but what I would say is I would start that off by saying that we have many doctors here today. We have many doctors who, I mean, Cliff McDonald was mentioned earlier. I mean, these are people who day in and day out go in, they want to save lives, they want to help people, they want to cure something. I would say 99.9% of people that work in healthcare go to work every day to do a good job and to help people, right? There's like that 0.01%, like that surgeon in Texas who's a sociopath, but they're very infrequent. And so being married into a family of doctors, somebody in our family recently went through a malpractice suit, and like the person was harmed, but it was an error. It was a communication error between a nurse and a doctor. It was just a mistake, but somebody was grievously harmed. In our system, who compensates that person for the harm? You know, their insurance doesn't want to pay for it because the doctor caused it. You know, so we have this kind of like weird system that says, let's make this guy whole. Like, let's figure this out. But my larger point about that is that I think that, you know, we have to have the voice there to kind of help, sorry, let me rephrase for a second. Like, I don't think people get up and want to file a lawsuit. Like, nobody wants to spend 10 years in court and in depositions because they got hurt in a hospital or got hurt through healthcare. Unfortunately, when the other levers that Chuck was talking about earlier are not used and are not well oiled and well muscled, then that becomes the only option you have left. So, Chuck, do you want to talk more generally about tort reform?
Yeah, I mean, I think the point you raise is really good, that people are left often in a situation where they have very extensive healthcare needs if they've survived negligence or malpractice, and they don't have a good way of providing for that. And it's in a system like we have where you have to purchase health insurance and it's not certain, and you may have many needs that goes beyond what health insurance pays for. So we think that consumers should have rights to seek accountability through the civil justice system when they are harmed. But the problem, as a practical matter, it's often quite difficult to do that, and so it's not a remedy or a solution for everyone. And so I think we have to face that issue. And, you know, one way of facing it is gradually and strengthening and improving health coverage for everyone in America, and that would go some of the way. It doesn't necessarily hold institutions accountable for grievous acts of negligence or failing to meet standards of care that we should expect from them. So from the medical side, from the hospitals and the AMA and groups like that, they are very concerned about what they call the culture of defensive medicine, which they argue may add as much as 50 to 100 billion to the nation's healthcare costs. But just taking away the right for patients to sue doesn't solve the great problems we have with medical harm in this country. With 100,000 or 250,000 medical errors and infections a year, we clearly, it wouldn't be a good solution. And so there are laws that are advancing in the Congress right now. There's 4 different bills that are really seeking to bar the door and make it much tougher for consumers to sue or be able to get an attorney who would take their case on a contingency basis that would also cap awards for non-economic damages like pain and suffering, so that even if you were able to sue, you might not recover very much. So I think it's a very complicated issue. There's a group in New York City called the Center for Justice and Democracy that has very good set of questions, commonly asked questions about tort reform and lawsuits and all that. But I think it's not a substitute for organizing a really broad social movement around ending medical harm. So I think reasonable people can differ about some of the issues relating to civil justice, but until we have better systems for holding institutions accountable, for improving care, and for helping to make patients whole, that's probably going to be very much in the mix.
Thank you. Thank you, Chuck. We have more tools than ever before in advocating and trying to defend and protect patients' rights, including under the Affordable Care Act and through reforms at the state level. But the key, as Eileen began to broach, rests with patients, caregivers, and families as advocates. That the utility of whatever recourse we have and the more tools that we've developed over the last 8 years really do come down to the ability and the fluency of ordinary people, individually and collectively, to use those tools. So I wanted to ask Eileen to talk briefly about the ways that you work with advocates and caregivers to help patients, and how do you concretely help develop those skills around advocacy and awareness in seeking recourse and in being informed consumers who are ready to, who know their rights and who are ready to assert, ask questions, and be good active citizens in this way?
Well, thank you for that question, because I'm very passionate about educating the public. The first thing that I think that's the most important is that with some of the boards that I'm involved with the National Patient Safety Foundation. I'm on the board of the Joint Commission as a public member for quite a few years. They know that there's a problem. That's why they're out there doing this kind of work. There's Institute for Healthcare Improvement. There's Institute for Safe Medication Practices. All these organizations have information for clinicians to give to their patients. The problem that I see is that it's not getting into their hands unless, as we said, they're going into the hospital. So something like the National Patient Safety Foundation has Ask Me three questions to ask your clinician. What is my problem? What do I need to do about it? And why should I do this? That's an educational tool to start the conversation between patients and families. There's Teach Back, where clinicians are asking their patients to repeat back what you heard me say so I know that you understand it. How do you get into that conversation with a clinician, a healthcare professional, about hand washing? Did you wash your hands? Well, nobody wants to ask their doctor that just spent 20 hours on their feet and went to 10, 20 years of school, who knows how much. Did you wash your hand? You ask a 5-year-old if you washed your hands. So how do we make that conversation comfortable for both people? And that's what we do in the classroom. As an advocate, when I get called to the bedside, it's usually strictly because it's a safety concern. We don't make the visit unless there's a safety problem already underway. And over the last many years, we've been doing it over the phone by talking to the family member who's at the bedside, empowering them with this information about how to have the conversation, who to go to. Don't ask the nurse if she has too many patients or if she's exhausted, or if there's a problem, who should you go to? Ask the nurse what the steps would be to file a complaint. Don't go over the nurse's head, because then you're going to alienate the relationship. Let the nurse know that you're not happy, and what do they expect you to do? How could you make their job easier because you're not happy with the care that your family member's getting? Understanding about infections, understanding falls in hospitals are a terrible problem. But having these conversations, I just did 2 presentations in libraries. We're going into another high school. I've been doing high school presentations, talking to the patients, the young people, just starting a conversation. Who likes their doctor? If they don't like their doctor, then they're not having safe conversation. That's where the heroin and opioid and addiction problem, I believe, are coming from, because young people who have a tonsillectomy, have knee replacement surgery, have access to drugs in their home, don't know that they can have these conversations with their doctor if they like their doctor. So having these conversations at a young age are starting the relationship between a patient and their clinician, and how to have safe conversations.
Thank you. Now, let's open it up to the audience. One bridge I'd like to make is reflected in Eileen's story. 27 years ago, she lost her son, Michael, to infections that were undiagnosed, but found later, after his death in 1990, that his body was riddled with infections. It led to a lawsuit some years later, and into Eileen's now 21 years of advocacy, educating, training people in how to be aware of frontline medical procedures and of their own protection and safety standards in seeking healthcare. And as you can hear, an incredible amount of passion and knowledge about how to translate some of those lessons into advocacy. But the one thing that's implicit in Eileen's story, and that binds many of us here together today, whether as professionals, with our own personal experiences as well, is pain. And we know that the pain of loss and suffering is an incredible catalyst for advocacy and for change and for seeking the protection of patients' rights, individually and systemically. So I wanted to ask any of you here today about any experience you have turning some of that pain into work around patients' rights, and any questions you might have for our panel.
So I actually have a question just about the whole patient's rights and what do you do when you are asking for information about it and you get some pushback. So for example, I went recently for a procedure, and as I was checking in and registering, I was asked to sign that I had received and read the patient's Bill of Rights. And when I asked for it, because everything's done on iPad, right? So I wasn't actually given anything physically. When I asked for it, I was told it's the standard Bill of Rights that's handed to you every time you go to the doctor. Well, I go to the doctor once a year. So I don't necessarily have it, and I don't know if it's changed. So I pushed back. They were all kind of snippy about it, but they gave me what I was asking for. But most people wouldn't push for that. They would just accept the fact that, okay, it's something I should know about, and not ask for the information if they didn't know about it. So what do you do as a normal person?
And of course, notions like that are gendered as well, that the branding of being a pushy woman rests particularly upon one part of our society, and it's an inhibition in itself. But I'm going to give Eileen a chance to answer.
Yeah, because my question is back to you. What did you do when you left there? Did you write a letter? Did you make a suggestion that the front office staff needs to be trained? Did you ask them to send out a copy on all billing about the patient's Bill of Rights so this never happens again? We need to follow up on that, and then send us a copy because I'll follow up for you.
I haven't yet because I have some other issues about billing and what the insurance has agreed to pay, which is roughly double what the normal procedure would be if I didn't have insurance.
I would start with one at a time, and if it means many letters, but that's really, and I'm not making light of what happened because I just signed a consent form, first name under, last name protest, because I was not signing this consent form without a conversation. So my name is not on any of my consent forms, which I probably shouldn't say that, right? But, well, it's there. But it really matters that we follow up on these things and send it to other organizations and even the media. Let the media know that you're doing this.
Sarah.
Well, just a quick follow-up to that, because the patient Bill of Rights that went in your hand probably gets handed with 20 or 30 other pieces of paper to someone or their family when they're coming into the hospital and really sick and have other stressors and other, like reading that document is not like the first thing on your mind. And so we're kind of doing it to check a box. And that's the same. It's exactly like it's on the iPad and it's checking a box. So shouldn't we be trying to educate people at a different time than their most stressful time when they don't have time to think about it?
Yeah, I mean, I think that, I think Eileen spoke to that pretty well earlier, which is like, how do we get this in front of people early on? And I think, the decline, the fragmentation of just how care gets delivered is a problem with that. And I think also the decline of people having kind of their general practitioner or that doctor that is kind of your home base. I think some of us still have that, but that would kind of be the person who should in some ways be educating you. But here's the rub. How is that doctor compensated for the time that they spend educating you about your rights? Unless an organization like ours is, was going to do that. And so there's all of this education that should be being done, but yet there's not necessarily the resources behind it to happen at the scale it needs to.
Yeah, I think one thing too is that patients have been acculturated to thinking that when you go to the healthcare system, you're talking to people that are in white coats and they're the experts and they're not really thinking that it's a place I'm going to have to stick up for myself and assert my rights. And so we have one initiative we've been doing at Consumer Reports, which many people may have heard about, is this initiative called Choosing Wisely. And we have these little cards that I put out on the table there. But we're trying to get people to have conversations with their doctor about possible overuse and overtreatment in medical services, especially on things like antibiotics, which relate very much to this issue. And so we've been trying to encourage patients to say, do I really need this test or procedure? What are the risks or side effects? Are there simpler, safer options? What happens if I don't do anything and just wait for a while? Would that be okay? And how much does it cost, and will my insurance pay for it? And so we've done this in partnership with the American Board of Internal Medicine Foundation and specific medical specialty societies. So the doctors also have these questions. And for particular specialties, there's another set of questions about, do I need antibiotics for a cold? And we want them to discuss these things together. But the other story I would just want to share is that Lisa McGiffert from our Safe Patient Project went to the hospital with her mom, and they tried to get her to sign an informed consent form just at the desk, like the form that you were talking about. And she says, no, I want the physician to explain to me the risks and the benefits of the treatment that he or she is recommending. And she said the doctor did a stellar job. So one option in that situation might be just go to the provider and take up your issue with the provider. Sometimes the frontline staff is just trying to get you on the way and doesn't want to.
And I just want to touch on that also, because they're usually not asking you if you read it and understand it. They're asking if you received it. And the same thing with the HIPAA forms. They're not asking if you read it and understand it. To keep in mind that I think 90 million Americans have trouble reading, I also believe that they should be asking, do you need help filling out these forms with every single patient? Because if you don't understand or you can't read, then you're absolutely not going to be getting the information.
Sir.
Just a question and a comment. The question is, tort has come up several times throughout this lecture series. Do you think that there should be professionally impaneled arbitration where it goes quickly? I don't know if you put doctors on it or not, but certainly the jurors don't know what's going on. And the second was is a comment. My brother had a very serious illness, and he needed this Optivo. And they said, sure, we'll give it to you. You just write a check for $48,000 because you're on dialysis and go jump. $48,000, so he wrote a check for $48,000. And it kept him alive essentially for 2 years. And there was an additional benefit. He's passed now, a legacy that because of him, the two medical papers were written, and now people on dialysis can get this treatment without having to put up $48,000. This whole business of the monetary, and I'm a capitalist, but the whole thing just stinks. I was part of that family. I might write a check for $48,000. Well, he did it, but how many people can do it? So go die. I was wondering what your comments
Well,
are.
let's deal with the first part of your question in specific. I know Eileen has experience doing training with local patients and advocates around mediation and arbitration as one route for recourse. And could you talk about that just briefly?
Well, I'm a strong believer. I've been trained as a mediator. We're bringing mediation and conflict resolution into our organization as an alternative. Arbitration, no, I feel very strongly about not doing arbitration. It's mediation. For years, though, we've been trying to partner with hospitals and healthcare organizations and clinicians on mediation, and their response has been, why sue us? Well, when, they just won't do it. So it's not something that's recognized. And then the other piece of mediation, or even if it was arbitration, who's going to pay for it? And that's been a problem because they expect the patients to pay for this. If they get a lawyer and sue, there's no payment until there's a win. I don't like that term, but a payment.
So actually, I want to address this because my hair could go on fire dealing with this issue right now. So I am actually completely and utterly opposed to forced arbitration in any form. We don't even realize the extent to which we sign things, we agree to software purchases, and we are literally signing away our rights to the courts on the daily. We did have a wrongful death suit after my mother died, and we did not sue the hospital because the hospital did everything they could to save her. But the people that put her in that state, the doctors responsible for that, were the people that we sued. And we settled. It was not a lot of money. I mean, the mythology around people getting rich from suing for malpractice is ludicrous, which doesn't mean that malpractice, a case against doctors, isn't horrible for that doctor, but it's horrible for everybody. I would be, to some extent, for the mediation and arbitration if it wasn't, but it's not. I don't actually have a problem with the idea of arbitration. Who picks the people doing the arbitrating? There's so I don't like the idea that you have to have a jury in a 20 week trial. There could be ways to do it better as long as the person doesn't giving up their rights. If it doesn't work, I want the right to still sue you. And I think that that's something that we have to take very, very seriously, not just in healthcare. In every aspect of our lives as citizens of this country, we have a constitutional right to redress through the courts. And I would argue, putting my political science hat on, that every tort reform and every tort law in this country is unconstitutional. They would not pass constitutional muster by any actual reasonable constitutional scholar. So I am completely against them, if I haven't made that clear enough. And I think we have time for just one more question.
Yeah, the final framing question for the panel is, from your perspective, what rights and protections should we be pushing for against C. diff? Or for people who've been touched by C. diff, or to prevent others from becoming touched by C. diff. A disease, an epidemic, which is changing and whose proportions still need to be recognized more fully within the medical profession and within society as a whole when we're dealing with sub 25% name ID amongst the public at large. But what is the one thing that you believe we should do to protect patients or to pursue protections to fight C. diff? And I'm going to start, yeah.
I think it is a lot like the time, as I mentioned before, we had protections against exclusion for pre-existing condition. I think it needs to be, we need a set of social rights for people not to be infected when they go to healthcare institutions. And so it's really like a whole change in the way that people think about what your rights are.
Freedom from fear.
Yeah, and there's all kinds of things that attach to that, obviously, as you've been discussing today, there's so many different aspects of how we would achieve that. But I think if the public demands, safer healthcare, and with like sort of a Bill of Rights for safer healthcare, we have to reframe the conversation. And this is my worry actually about the tort reform conversation is we're not really having the conversation we should be having about how badly people are damaged by medical harm in America. We're not even tracking a lot of the errors and infections that happen to people. And so it's such a skewed conversation. I think that this movement that you are in is just so badly needed for fixing this. And I also just wanted to share one little victory that we had at Consumer Reports, because we work on trying to get antibiotics out of food production and excessively used with farm animals. And we just had 2 weeks ago, Kentucky Fried Chicken agreed to new guidelines not to use overuse antibiotics. So we can make progress when we get organized, and it doesn't take like the whole country to be organized. 40 people in a room like this can do incredible, amazing things. So thank you, guys.
Thank you, Chuck. Thank you.
So I'm getting the wrap it up indication from Vicky. So, but the one thing I would say actually, I believe in the right to know. I feel like any hospital that we go to in New York State and plenty of other places, when you go to a restaurant, they have a rating. It's an A rating, a B rating. My brother Liam will not go into a B-rated restaurant. He will not eat there. And I feel like as a healthcare consumer, I think all nursing homes and all hospitals should have an A, B, C, or D infection rating, and that you should have the right to know. And if I'm going to submit myself, I should be able to say, how many C. diff cases have you had in your hospital this year? And you should have to tell me. Because that's being an informed consumer. Oh, they track it internally, trust me.
Thank you. Thank you. And as many of you know, that kind of spirit led to Hospital Compare, and it's led to Nursing Home Compare, but we do not have similar kinds of comparison informed consumer platforms at the state level, which is very important for the level of governance closest to the people and for informed consumer behavior. Last word on this to Eileen.
I can't add to it, so I'll pass.
Wow.
I agree.
Well, thank you, panelists. Thank you for the questions from the audience, and we will be back shortly with our final panel.